So, what did I say was the average heart rate? 70. And average stroke volume? 70. So that gives us an average cardiac output of 4,900 mils per minute, okay? Which we actually just round up 5,000, which is equal to 5 liters. And this helps to maintain an adequate blood pressure for the distribution of oxygen throughout the body. So if your blood pressure drops, then the blood's not going to be flowing as fast, and you're not going to be getting the same amount of oxygen distributed to each organ over the same amount of time. So, when we talked about cardiac tamponade early on in the anatomy part, so cardiac tamponade, stroke volume decreased, right? Because the fluid in the pericardial sac didn't allow the ventricles to expand as much. So if we cut our stroke volume down to 30 mils, what do we have to do to the heart rate to get, let's make it easy. Too late to do the math in my head. So if we drop the stroke volume to 50, what does heart rate have to go up to keep our cardiac output at 5 liters? 100. Okay? And the heart will do that with its autonomic responses from the sympathetic nervous system. As blood pressure drops, we have pressure receptors in the aortic arch and in the carotid artery, just as it branches to internal and external carotid artery. So if you get stronger, if you are running or swimming or doing cardiac type exercises, so that each time the ventricles contract, they pump out 100 mils instead of 70, and what can happen to your heart rate? It can drop down to 50. All right, so it goes both ways. The stronger the heart, the more the stroke volume is. Each force of contraction is pumping out a greater volume, therefore the heart doesn't have to contract as often. Okay, so it's kind of a seesaw relationship between the heart rate and stroke volume. So we've already talked about the factors that affect the heart rate, our autonomic nervous system. Okay, so sympathetic nervous system, the cardiac accelerator fibers are going to increase heart rate, and parasympathetic is going to decrease heart rate. When you look at when you do the Physio-X, you will also look at the effect of certain drugs that are mimicking the sympathetic or the parasympathetic heart rate. Okay? So norepinephrine is our neurotransmitter for sympathetic. Some of the drugs that you're going to look at are pilocarpine, which is often used in the ophthalmology or optometrists, atropine, and an old-fashioned drug known as digitalis. Okay? You're going to drip these onto the frog heart, or at least simulate that you're dripping them onto the frog heart in your Physio-X activity over the weekend. Now, if you want a drug to act as norepinephrine, we can do this in a few different ways, right? We talked about this a little bit in our class that I had with some of you last spring. So, remember we have in the parasympathetic nervous system, we have our preganglionic neuron, and it releases acetylcholine to our postganglionic neuron, and except in the penile arterioles where we have nitric oxide, this also releases acetylcholine. You guys remember all that? Yes, you do. Then with the sympathetic nervous system, the preganglionic neuron also releases acetylcholine. But unless we're talking about sweat glands, the postganglionic releases norepinephrine. Okay? We talked about a cholinergic crisis. I don't know if you guys remember that, but there's a condition where the body makes antibodies against acetylcholine receptors, and the antibodies block the acetylcholine receptors, and it causes a paralysis, because acetylcholine causes your skeletal muscles to contract as well. And it usually starts in the head and moves down the body. I have no idea why. But often people have trouble, they can't open their eyelids. And then it moves down the neck into the chest, and they have trouble breathing, because breathing muscles are voluntary muscles. So one of the treatments is to give them lots and lots of acetylcholine, all right, or some way of increasing acetylcholine. And that can affect both parasympathetic and sympathetic systems, because we have acetylcholine between pre and post-sympathetic. And so the symptoms vary. We see digestive symptoms because of the parasympathetic, so diarrhea, all right? But we also see sympathetic systems. The heart is more likely to be affected by the increased acetylcholine to increase heart rate than it is to decrease heart rate. So sympathetic is more sensitive to that. And so you'll see increased heart rate, increased blood pressure as a result of too much acetylcholine. And that's because the sympathetic uses acetylcholine here between the pre and the post. All right, so we're trying to increase the effect of norepinephrine here. We can use a drug that binds to the same receptor. It acts just like norepinephrine by binding to the same beta receptor or alpha receptor that norepinephrine does, okay? And that's called an agonist, or a sympathomimetic drug. It mimics norepinephrine by doing the same thing norepinephrine does. Does anybody remember an enzyme that breaks down norepinephrine? It's a little weird because norepinephrine is taken back up into the nerve ending that released it. Does that sound familiar to anybody? MAO? MAO inhibitors? Yeah. So MAO, norepinephrine is, if you recall from our hormone, is a modified tyrosine amino acid. So this is a monoamine oxidase. And once norepinephrine is released, the extra norepinephrine is taken back up into the neuron that released it and is broken down by a monoamine oxidase, all right? Well, if we want more norepinephrine in the synaptic cleft, then the person can be given an MAOI, which is an inhibitor. So what happens if we stop breaking down norepinephrine? We're going to end up with more of it here. So it's like giving the person a drug that acts like norepinephrine, okay? So we can either give them a drug that acts like norepinephrine, or we can give them a drug that prevents norepinephrine from being broken down, and that's an MAOI. Okay, so you would expect that a side effect, if it's not what you want to happen, or too much is given, or maybe it is what you want to happen, the effect of an MAOI is going to increase heart rate and increase blood pressure because of an increase of the force of the heart's contraction. Okay, so it can either bind to the receptor itself and act like norepinephrine, or it can increase the amount of epinephrine that's already there. How else could we increase heart rate? Indirectly. By blocking what acetylcholine does, right? So if we have a drug that blocks the binding to the acetylcholine receptor but doesn't activate it, a cholinergic blocker, that's also going to then allow, it's going to keep the vagus nerve from slowing the heart down, and it's going to allow the SA node to fire at its more rapid normal rate. So a cholinergic blocker all of these will have the same effect as, or similar effect to norepinephrine. So a cholinergic blocker keeps acetylcholine from working, and that allows the heart to go back to its normal higher heart rate. Okay? Now, what if we wanted to do norepinephrine is an adrenergic drug. Okay, so that's the term for adrenaline. So acetylcholine, and some of these are going to be for norepinephrine, and some of these are going to be for acetylcholine. You'll see that when you do the physiologic activity. So this is to increase adrenergic effects. What if we want to increase cholinergic? Okay, we can do the same thing. We can have an agonist. We can have a drug that binds to the acetylcholine receptor and acts just like acetylcholine. Okay? Of the drugs I had up here, that's what pilocarpine does. Pilocarpine binds to the acetylcholine receptor and does the same thing on that acetylcholine receptor as acetylcholine does. All right, instead of an MAO inhibitor, how do we get rid of acetylcholine in the synaptic cleft? Acetylcholinesterase. All right, so we can have a drug that blocks acetylcholinesterase, and that's called an anti. So by keeping acetylcholinesterase from functioning, we get more acetylcholine to remain and maintain its effects longer. And then instead of a cholinergic blocker, we can block norepinephrine. And those aren't called adrenergic blockers, they're called beta blockers. So this will keep norepinephrine from binding to its receptor. Okay? So those are different ways that drugs.
What does the beta blocker do?
Beta blocker is going to block norepinephrine from binding to its beta-1 receptor site.
What is the cholinergic blocker?
Pardon?
What does the cholinergic blocker do?
Cholinergic blocker is going to keep acetylcholine from binding to its acetylcholine site, and thus remove vagal effects. And then we have there's a whole bunch of different types of drugs. We'll talk about this when you come back next week. But there are calcium channel blockers, okay? They're not specific to epinephrine or norepinephrine, but can change the force of the heart's contraction, or sometimes they're used for controlling arrhythmias. So that's heart rate, okay? So remember, this is just a review of how norepinephrine works, or drugs that act like norepinephrine, cause the same thing. So this is from Thursday's lecture last week, where norepinephrine activates cyclic AMP, and cyclic AMP opens plenty channels and activates protein kinases that open the transient calcium channels. Okay? And there's the answer to your second quiz question. Those are beta-1 receptors. I was asking what the receptors are in the heart. Okay? Norepinephrine also opens calcium channels in the ventricular muscle. Okay? So it'll open calcium channels in the sarcoplasmic reticulum, and it will open calcium channels on the outside of the muscle cell, which we didn't have in skeletal muscle. So in the contractile cells, when norepinephrine causes these calcium channels to be opened, is that going to affect heart rate as much? Or contractile force? Contractile force. Okay, so that's what we're going to lead to as we leave heart rate control. And this is just the acetylcholine. So acetylcholine, remember, had gamma beta receptors opening potassium channels, and then it inhibited cyclic AMP from being formed. Those are the two ways that acetylcholine works. All right, so that's heart rate on our cardiac output formula. And the other is stroke volume. So stroke volume is dependent on these three factors that I have up here on the board. So we'll discuss those, and then we'll stop and work on ECGs. Okay, that will be the end of our lecture content, which I know I've gone pretty heavy tonight. So preload is the same as end diastolic volume. preload is how much blood is in the ventricle before it starts to contract. And keep these rubber bands here, not just for the microscope, it's going to help me with this concept here. So as we increase preload, more blood in the volume of the heart is going to increase the force of contraction. All right? And that's due to, I changed the diagram from last night, Kate. So that's due, to keep leaving off Mr. Frank's name, the Frank-Starling law. And what that says is the more blood that goes into the ventricle and stretches the muscle cells of the ventricle, the greater the force with which the ventricles will contract. So if you look at the rubber band that I have on my fingers here, all right, when I stretch that out and then I relax my fingers, that elasticity in the rubber band brings it back to the same shape it was when it was relaxed. Not anymore, just back, just back to its resting shape. The more I stretch it, the greater the change to come back as well. Okay, if I open it just a little bit, it only comes back a little bit. If I open it a lot, it comes back a lot. Now we have the limit in cardiac muscle, of course, if we stretch it too far, actin and myosin are not overlapping anymore, and we lose our efficiency. Okay? So that preload is illustrated here. So here's our normal in diastolic volume. You will see this diagram on the exam as well, electric exam. Okay? So here's our normal in diastolic volume. And our stroke volume of 70 leaves us with a little less than half, 65 mils is our end systolic volume. All right? Then we increase the blood volume in the heart. We increase preload up to whatever, I've chosen 110 here. So we've increased the volume, but notice when the heart contracted, it came back to the same end diastolic volume. That's what Starling law says. So if we increase the volume, the heart will contract more to come back to the same end diastolic volume. The more the heart stretches, the more it contracts, but it's still just increasing the amount to the degree that it was filled more. Okay?
Wait, oh, sorry. Before
Yeah.
you go, is that one gonna be out? Because they're different.
Yes, I changed it from last night because I drew this other one on there. Because I just had this one, and this one actually includes both, but I wanted to separate stroke. I wanted to separate Starling's law from contractility. I wanted to separate venous return effect from contractility.
Is it on the card?
Pardon?
Is this one on the card?
No, I just changed it this afternoon.
I can send it. Can you say that again?
Yeah, so Frank preload, or Frank Starling's law, says that the more blood that comes into a ventricle, it doesn't matter if it's the right or the left, the more blood that comes into that ventricle, the greater the end diastolic volume, the greater the force of the heart's contraction to get rid of that extra blood that's come in. So we have twice the amount of blood coming in, we're gonna have twice the amount of blood going out, just so that we can bring it back to our normal end diastolic volume. And it's that stretching of the muscle fibers that triggers that greater force of contraction. Okay? Now, things that can increase venous return, we have a finite amount of blood in the body, okay? And if you drink a lot of fluid, yeah, your blood volume's gonna go up, but you're likely, if you're healthy, you're gonna pee it out. So our body's fluid volume stays pretty level, and if you don't drink enough, then you don't pee as much. We try to maintain that blood volume. So, however, if the heart rate slows down, what happens to ventricular filling? We have a longer time, right? So if I have a filling time of 1 second at 60 beats a minute, and I increase that to 1.5 seconds, I'm going to have more blood coming into my heart, right? So then that force of contraction is going to be greater, which is why I've said acetylcholine will slow the heart rate down. So indirectly, it will increase the force of the heart's contraction, but only indirectly, okay? Acetylcholine itself doesn't bind to the ventricular muscle, so it's not going to cause that muscle by calcium ion changes to contract more. but by slowing the heart down and increasing filling time, it will contract more due to the filling, not because acetylcholine is actually causing the ventricle to contract more. All right, exercise. And what I'm thinking of here is a couple of things. First of all, when you exercise, especially in your lower limbs, we have what's called the skeletal muscle pump. And I used the illustration last night. If you have a toothpaste tube, a regular tube, and you squeeze it, the bottom end should be closed, right? So toothpaste only goes out the open end when you take the cap off, even if you grab it and squeeze it in the middle. But if you cut off the bottom end, as well as take off the cap, then when you squeeze it in the middle, it's gonna go out both ends, all right? So as we'll see next week, our veins in our, especially our deep veins in our legs are set up with valves. So that when we walk, the ones that are deep in our legs near the bones, and deep in the compartments, when they contract, our muscles go from relaxation to that as they're contracting. When they go like that, they squeeze the veins. Without the valves, the blood flow would be squeezed both directions. But since we have valves, it's only going to go a short distance back, and most of the force is going to go that direction, and that sends it back to the heart. So exercising, walking, using your leg muscles, squeezes the veins and acts as a second pump to return blood to the heart. That increases venous return as well. Okay? So these are different things that